Good morning, everyone. I'm Garishma. I'm one of the surgical SHOs at Our Lady's Hospital in Navan. Thank you for the opportunity to present at Matter Grand Rounds. So my topic for today is on occult surgical pathology in the acute medical patient. Our first case was that of a 73-year-old male who had presented to ED with shortness of breath, chills, and cough for about 2 days. And in his past medical history, he had had lymphoma and chemotherapy, ischemic heart disease, and an appendectomy. He was alert, orientated, but moderately distressed, and his vitals were unstable. On a chest X-ray, he had right-sided consolidation and no ST elevation was seen on his ECG. His bloods were increased, inflammatory factors, troponin was 502, and his LFTs were perfectly normal. He was then admitted to ICU with a clinical diagnosis of respiratory sepsis and an NSTEMI. He was placed on tazocine and therapeutic anticoagulation. However, he did deteriorate between 2 to 3 days, and blood cultures would have yielded an E. coli sepsis, so his antibiotic was changed to meropenem. He had no abdominal symptoms or signs. A CT tap was done as he was continuing to be septic. And here, you would be able to see a large multiloculated abscess in his liver, secondary to a perforated gallbladder. He had CT-guided drainage suggested by radiology, and a cholecystostomy was done. This gentleman has ongoing complex management with the oncologist and cardiologist, and his later follow-up of a CT showed no hepatic abscess, cholelithiasis with no acute inflammation, and no recurrence of his lymphoma, thankfully. This is a radiograph showing his pigtail drain in situ. The second case is that of a 67-year-old gentleman who presented to our ED with nausea, rigors, shortness of breath. He had had a severe headache radiating from the frontal to the occipital regions. He had significant back pain, neck stiffness, photophobia, and weakness. He was febrile with stable enough vitals. His CRP was 239.8, and he was resuscitated with IV fluids. In his past medical history, interesting for us, he had a previous meningitis episode. He was a type 2 diabetic, and he was on intermittent steroids for knee and ankle arthropathy. His working diagnosis was query meningitis, query encephalitis, and he was started on a protocol. His chest X-ray, nothing. Urine, nothing. CT brain was normal as well. An LP was done, and since there was no evidence of bacterial infection, all of his antibiotics were stopped. The acyclovir was continued until the PCR came back negative for herpes simplex. This patient was admitted to ICU, and on day 2 of his hospitalization, he developed abdominal symptoms and signs. So a CT tap was done. I'm going to direct your attention to this bit here. That is acute diverticulitis. This gentleman was placed on IV antibiotics and managed non-operatively, therefore, and he did quite well with that. So the third one was of a 77-year-old female with central chest pain radiating to her left arm, nausea, fever, and diarrhea. In her past medical history, she had had autoimmune hepatitis, and she was on Imuran, the drug azathioprine. She also had ischemic heart disease and hypertension in her background. Temperature was fine enough, and her vitals were stable. She was borderline tachypneic and tachycardic. Troponin levels were equivocal. CRP was 92.8. Chest X-ray and urine analysis were normal. She had absolutely no abdominal symptoms or signs. LFTs were perfectly normal. She had an interval ultrasound suggested by her gastroenterology as follow-up, and this is what it showed. A thick-walled gallbladder that contained echogenic fluid. This is the thickness of the gallbladder wall. Previously, on previous scan, she had actually had gallstones, but they weren't seen on this one. And she had these hypoechoic lesions that were seen in the liver. So she had an MRI to further evaluate those lesions. And this is an MRI slice where you can see her distended gallbladder here and one of the hypoechoic lesions. They were felt to be more inflammatory, in fact, in nature, so more hepatic abscesses than anything else. This lady did improve on IV antibiotics. She was not suitable for percutaneous intervention. And she did, of course, have a surgical review with a hepatobiliary consultation as well. She had ongoing chest pain. It eventually culminated with ST elevation, and she thus had a PCI and stenting of the left circumflex artery. She had a follow-up CT done in Navan, and she had a thick-walled gallbladder and multiple hepatic metastases. So ultrasound guided biopsy was done. This was found to be a primary biliary tumor, and she's currently an inpatient at St. Vincent's receiving chemo. The fourth case is that of a 47-year-old gentleman who is generally unwell, had a frontal headache, feverish, urgency, proctalgia, and diarrhea. He had a background history of ulcerative colitis. He was on asacolon, pentasa. I'll draw your attention to the fact that he was on Humira and immunosuppressant. His vitals were stable enough and urine was fine, but his bloods were perfectly high. Of course, he was commenced on our septic regime, and his abdomen was soft and non-tender. But he did have a paucity of localizing signs pointing to a possible source of infection. He didn't have a lung puncture done, as his INR was 1.7, and a microbiology consult effectively changed his antibiotics to cefotaxime and vancomycin. Chest X-ray, CT brain were perfectly normal, and a CT tap showed multiple hepatic abscesses, and here's your culprit, the appendix, acute appendicitis. The white dot is an appendicolith. So he had laparoscopic drainage of these abscesses done, and they yielded a Streptococcus intermediate bacteria. He settled quite well on IV antibiotics via a PIC. And his CT imaging post-procedure did show a decrease in the abscess size. He had an interval appendicectomy, and that effectively settled his ulcerative colitis as well. Case 5 is that of a 79-year-old female who presented to ED with shortness of breath and shaking, confusion and a poor appetite. She was worked up via our septic pathway, and her CRP was 36.4, LFTs were perfectly normal. Her urine analysis was rather suggestive of a urosepsis. In her past medical history, interesting for us would be atrial fibrillation, a CVA in 2013, and arthritis of the spine, for which she would have received steroids. The provisional diagnosis for her was that of a urosepsis, query and intracranial bleed. Chest X-ray was perfectly normal. The CT brain showed nothing acute at the time, and on day 3 her temperature spiked. She was cold and clammy. She was transferred to ICU, and we did an abdominal ultrasound for her. And this is what it found: a thickened gallbladder with multiple gallbladder calculi. Here you can see the distended wall. And this is her CBD. So she had an ectatic CBD. This is 1.3 centimeters. The distal portion of her CBD was not perfectly seen at this time. She had a CT that was done later on as well. And here you can see the gallbladder very well with pericholecystic fluid around it, indicating the active inflammation. And she was considered to be for IV antibiotics, not for surgical intervention due to her other comorbidities. This lady has had a repeat ultrasound, and her CBD is dilated with an 8mm stone in the distal CBD. She is for discussion with her family as she has ongoing delirium. The last case for today is that of a 79-year-old male who presented with central chest pain. He was given aspirin and sublingual nitroglycerin in the ambulance. Vitals were stable enough, and he had normal heart sounds on auscultation with no murmurs. ECG did show an ST elevation. His troponin was 1522. White cells were increased in neutrophils as well. In his past background history, he had hypertension, borderline diabetes, and gout. He was diagnosed with a STEMI. He had come up to the cath lab, had a PCI and stenting. When he returned to Navan, he had a deterioration in renal function, so an ultrasound was done. And this is what it picked up: these enhancing lesions in the liver. This is a granuloma found in the left lobe of the liver. This is the gallbladder, which is perfectly normal, no thickened wall, no inflammation. This is a gallstone that is seen within the gallbladder. So this gentleman had a CT abdomen pelvis in order to further look at the lesions in the liver, and this is what they found. Over a region of 8 to 9 centimeters, you could see these tiny echoic lesions with little foci of air in between, indicating necrotic liver tissue. I will also draw your attention to the fact that he had extensive diverticular disease, but no active inflammation at that time. His blood culture showed E. coli sepsis, which is where we were thinking about bowel, but he did have a surgical review, and conservative management for him eventually resulted in resolution of those abscesses. He is for follow-up in outpatients. So sepsis is derived from a Greek word sepsi, meaning to make rotten. Sina had observed the frequent coincidence of putrefaction and fever, which were both common consequences of surgery 3,000 years ago. Sepsis is defined as the clinical evidence of infection, and vital signs and bloods are used to categorize it. Sepsis 6 is a famous regimen. Give 3. Give oxygen, give IV fluids, give IV antibiotics. And take 3. Take a urine sample, take a blood sample, take ABGs and other bloods. With advances in specialization and subspecialization these days, it is becoming increasingly difficult to direct your acutely unwell patient to the appropriate specialty in a timely manner. On occasion, this will become painfully evident when you are discussing your mortality and morbidity. This may be associated with a prolonged interval between presentation, diagnosis, and appropriate intervention. This is particularly the case with occult sepsis. There is a significant cohort of septic patients that are admitted medically with a bona fide medical reason for their sepsis, like lower respiratory tract infection, sepsis, meningitis, as seen in the cases we presented today. But of course, they would have an occult surgical source as well. With the development of the acute medical assessment units around the country, our physician colleagues are becoming more and more alert to the possibilities of their medical patients having occult surgical sepsis. There are risk factors for these occult presentations: advanced age, multiple comorbidities, those that are on immunosuppressants for comorbidities, those that are immunosuppressed because of comorbidities, atypical presentations, and limited differential diagnoses at the time of presentation. We have to think outside of the box. To recap, the text in bold are those cases presented today. There was a 73-year-old, respiratory sepsis and STEMI, background history of malignancy and chemotherapy, ended up with a hepatic abscess secondary to a perforated gallbladder. 67-year-old, meningitis encephalitis on steroids, acute diverticulitis. 77-year-old with N-STEMI on Imuran, a gallbladder tumor. 47-year-old with diarrhea, exacerbation of an inflammatory bowel disease on Humira immunosuppressant, and acute appendicitis with multiple secondary liver abscesses. 79-year-old with urosepsis and multiple comorbidities, acute cholecystitis. 79-year-old, STEMI, diabetic patient, multiple liver abscesses with foci of gas and incidental cholelithiasis. These series of cases demonstrates the importance of multi-speciality consultation, multi-center care, with transfer to a level 4 unit where clinically indicated. There is a wide range of imaging tools that are available for investigation of abdominal sepsis, and the choice of your imaging modality will depend on many factors. Most important, what is the clinical condition of your patient? Are there or are there not the presence of localizing signs? For the benefit of any medical students or interns, the ultrasound is possibly the best initial imaging method you could have for a sick patient. It is portable for patients that have symptoms and signs that are localizing to the right upper quadrant, the renal area, subphrenic, and the pelvis. Transvaginal ultrasound is particularly useful in examining the pelvis. CT would be your imaging modality of choice for the pancreas, the retroperitoneum, poor candidates for an ultrasound, and those whom you would expect visualization on ultrasound to be inadequate. In patients that don't have localizing signs or symptoms but are septic, you could use nuclear medicine studies, but then you would also require CT or ultrasound to further give you detailed anatomy. And of course, you could use ultrasound or CT guided drainage and aspiration, thus eliminating the need for surgical interventions in your really sick patients. This is a paper that was written by a doctor and done in the emergency department at King's College in London, and he used a cohort of about 50 patients. Interestingly, he found that the two most common things done in our ED, chest x-ray and the urine analysis, would identify your septic focus in about 60% of the patients. 14 of the remaining 20 of his group went on to have radiological imaging in order to have their septic focus identified. This paper demonstrated the benefit of further imaging in confirming a focus of infection to guide definitive treatment, and instances where this further imaging was delayed by several days highlights the needs for guidelines that will detail which investigations need to be done and when you need to do them. So in conclusion, sepsis may present in a variety of ways, and it may be occult. Common pathologies will frequently present in an atypical fashion. Remember, uncommon pathologies will present uncommonly. Consider your differential diagnosis wisely. There is a paucity of symptoms and signs in the elderly and in the immunosuppressed. Patients that have clinically suspected sepsis must have appropriate radiological investigations early to facilitate appropriate intervention and treatment. And the diagnosis and management of septic patients is a team effort. Thank you for your time and attention.